Resource Center. Today is Wednesday, November 13th, and this is our November TASC 90 focused on population health, the return on investment tool kit scenarios, and readiness assessments. Today we have Tracy Morton, the Director of Population Health from the Center, and the Program Manager at TASC to help to discuss population health. We also have updates from our federal partners, the Federal Office of Rural Health Policy, ARKITA, and Stratus Health, as well as the Flex Monitoring team. All lines are muted via default. If you need to ask a question, *2 will unmute your line, but I will also draw your attention to the little figure up at the top left of the meeting where you can raise your hand, agree, disagree, step away, ask the speaker to speak up or speak a little softer, slow down, as well as the chat feature on the left there if you have any questions or announcements that you'd like made or to participate in the discussion. There's also a file share box in the lower left hand where the presentation as well as the updates can be downloaded for future reference or to share with your friends. If we don't have anything, I will start with the TASC updates and then let Sarah Young as well as our other partners go from there. So a couple updates from TASC. Please take a moment to update your state Flex profile on the website. The deadline has passed, but we have extended it to the 22nd. Please take 10-15 minutes to update your state Flex profile on the website. A link I'm sure will be coming shortly, and as well as has been sent out. The reverse site visit dates have been released via email earlier, I believe last week, August 5th and 6th in Washington, D.C. Registration will open sometime in April. So look for more information and updates related to the reverse site visit, August 5th and 6th. The EMS resources, we've got tons of them coming out or on their way out now. Nicole, do you have anything you'd like to say on that really fast? Otherwise, I can make those announcements for you. The new guide titled Rural Emergency Medical Services Integration Guide is now available and on the website. It is a practical guide for ambulance services to use in their pursuit of sustaining effective and efficient delivery of patient care and developing into an integrated system with other agencies. Provides insights from agencies to promote integration to the benefit of the agencies, to the staff, and most importantly, the patients. And we have also released a summary of an EMS stakeholder meeting held in March to discuss rural emergency care integration. The report incorporates the summit proceedings as well as a list of key strategies for rural ambulance services and hospital leaders to deploy when engaging collaboratively in transition to value-based payment and care delivery models. The document is titled Flex Program Support for Rural EMS, Moving from Loaded Miles to Value-Based Models. Also a reminder that back in July we released the Rural Community Ambulance Agency Transformation Toolkit, which provides resource collections and self-assessment and a self-assessment for rural ambulance services to gauge their progress toward value and population health. Also, keep an eye out for an email from Nicole soon with links to these as well as an update about other resources coming soon. So as I said, we've got a ton of EMS related resources coming out. And another reminder related to National Rural Health Day is November 21st. The National Organization for State Offices of Rural Health has tons of resources and ways to participate in the celebration or notice or recognition of that day on their website. Those are all of the TASC updates that I have. Sarah Young, *2, will unmute your line for our Flex program update.
Thanks, Caleb, and I already unmuted, so you should not have to wait for me. On top of things today. A couple of quick program level updates. I wanted to say thank you again for everyone completing your PIMS reports for your Flex reporting this last month. I realized there were a number of frustrating technical challenges with the PIMS reports, especially in the last 2 weeks as the IT system was working poorly. So thank you for persevering through that, and I am really sorry for the frustration that caused. I know I heard from some of you, and many of you probably went directly to the HRSA help desk. I don't have any more information right now about the root causes of those IT problems, but I have asked the folks who are looking into it to please circle back with us and let us know if there's any lessons we can take for the future. And I will be reviewing the PIMS data, and I'll reach out if I have any questions about the data from individual states. The other program news that most of you on this webinar have probably already heard is that once again, I want to say welcome to Natalia Vargas as our new MBQIP coordinator. Natalia joins us from AHRQ, where she was involved in measure development and quality measure processes. So she's bringing some really great experience to her new role as MBQIP coordinator. And Natalia will also be stepping up as a project officer for 11 Flex states. So as you have a chance to meet Natalia, either on telephones or webinars or face-to-face, please do say hi. And those of you who are coming to the NRHA Policy Institute in February, that will be one opportunity to meet face-to-face. And the one other thing I wanted to add to Caleb's announcement about the reverse site visit is, of course, well before registration opens up, there will be requests for feedback and input on reverse site visit planning and topics of interest that we need to include in that meeting. So please stay tuned for that also. And that was all I had. I'll turn it back to you, Caleb.
Great. Thank you very much, Sarah. Carrie Conejo from the federal office. *2 will unmute your line.
Hi there. Can you hear me all right?
I can. Great. Thank you.
Perfect. Hi, everyone. So I'm going to give some updates on some policies and regulatory issues that have come out recently that are going to be relevant for critical access hospitals. So the first one I'm going to talk about is the Medicare Outpatient Prospective Payment System final rule. That will be effective on January 1st, 2020. Especially relevant to critical access hospitals, this rule finalizes changes regarding the level of supervision for outpatient therapeutic services in hospitals and critical access hospitals. So this is codifying this in regulation. It also does not implement the proposed requirements for price transparency that you might have heard about making standard charges for items and services available online, and then charge data set for shoppable services. CMS has indicated that they plan to finalize these provisions in a standalone rulemaking at a later date. CMS also finalized paying the average sale price minus 22.5% for 340B acquired drugs, but as a reminder, this continues to not apply to rural sole community hospitals, and it also doesn't apply to critical access hospitals, but it's good to be aware that this is going on. Just some other items of interest in the Outpatient Prospective Payment System rule. I won't really go over it. It's not going to be as relevant to critical access hospitals, like around the wage index, just implementing the changes that were made for the IPPS and the OPPS, completing the phase-in of the site-neutral payments, and then just updating payment rates generally. CMS also, around the same time, released the Medicare physician fee schedule rule, and specifically addressing cause in the rule. This codifies the regulation that repeals the therapy caps and the limitation to ensure appropriate therapy. So some other items of interest. This was a really big rule. A lot of different things came out, adding 3 new codes to list of telehealth services, and these have to do with the treatment of opioid use disorders, also implementing coverage for opioid use disorder treatment services and opioid treatment programs beginning in calendar year 2020, and then creating a new code for principal care management. So unlike the chronic care management, this is for patients that have only one single high-risk chronic condition. Also in that rule, some other items, some flexibility for physician assistants, and then some updates to the E&M coding. And then there are some updates related to ambulance services, the most major being the new ground ambulance data collection system. So the rule has a lot more detail, and I'd be happy to answer any follow-up questions you might have. But just for the purposes now, this includes finalizing the data format and elements, the sampling methodology, timelines, payment adjustments, and hardship exemptions. Other items too, this rule contains rulemaking for the quality payment program, and CAUSE may participate in the quality payment program and adjust some of the performance thresholds for the merit-based incentive payment system, also known as MIPS, to be able to get that positive payment adjustment. It also talks about the MIPS values pathways, this will be a new participation framework that would begin in 2021. And then also, the rule just makes a quick technical correction to the definition of rural that's used in the MIPS program. So they're actually using the same definition that they were before, but this rule just identifies the correct source file in the regulations. And on these rules, I know Sarah had sent around some brief documents looking at the discharge planning rule and the burden reduction rule, so I won't spend a lot of time here. But I just wanted to make sure to add it to these slides just to keep it in your attention. But this is the new policies and new condition of participation on discharge planning for critical access hospitals, and then some cost-specific updates in that burden reduction rule, some of the most prominent being the new condition of participation for infection prevention and control and antibiotic stewardship, and then modifying the COP that would establish the quality assessment and performance improvement programs in critical access hospitals. Just some other items of interest. There's an opportunity to comment on a heart failure measure for MIPS, and comments are being accepted through November 27th. Just that open enrollment for the health insurance marketplace has started, and that ends on Sunday, December 15th. And then the deadline to respond to the RFI on the FORP website on rural health grants eligibility, the deadline for that is November 23rd. And then, of course, as always, if you have any questions, please don't hesitate to reach out. You can contact us at ruralpolicy@hrsa.gov.
Great, thank you very much. Any questions for either of our federal office updates? Hearing none, I will move to, I believe it's Carla from Stratus Health.
Yep, I'm here. Can you hear me, Caleb?
There you are. Afternoon.
Good afternoon, everyone. A handful of MBQIP related updates to share. There are a couple upcoming events next week that I wanted to highlight. In addition to being National Rural Health Day next Thursday, with a lot of celebration pretty much the whole week for that, it's also CDC has declared next week as Antibiotic Awareness. So there is actually a co-sponsored session by the CDC and the Federal Office of Rural Health Policy next Wednesday, focusing on improving antibiotic stewardship in critical access hospitals, strategies and success stories. So would be a good one to highlight for your hospitals, particularly with the changes in the conditions of participation, and focus on that. Antibiotic stewardship is part of that. We've also been trying through the MBQIP monthly, both last month and this coming month. We're doing profiles specifically highlighting hospitals who have done antibiotic stewardship implementation, so highlighting those as another resource. We also have MBQIP Virtual Knowledge Group next Thursday. I know that's Rural Health Day. Hope that lots of you will join us for that as well. And then the next slide, a handful of resources to share. We did just release about a month and a half ago antibiotic stewardship implementation. Again, this is suggested strategies from high-performing critical access hospitals. We did focus groups earlier this spring with a good handful of hospitals all over the country and have highlighted the strategies that they're using to implement antibiotic stewardship. We also have released this spring an online QI Basics course. That link will take you to the online Basics QI course, but there's also in the next week or so we'll have a facilitator guide coming out. So if you wanted to work with a group of critical access hospitals to do sort of a learning network to walk through those courses together, it'll be a guide that will help you structure and implement that. We've been spending a fair amount of time over the last several months, year or so, actually focused on the revisions that are coming for the emergency department transfer communication. So I just want to take a couple minutes and talk about that briefly. Just a reminder that through Q4 2019 data collection, so the data quarter that we're in right now, critical access hospitals should be continuing to use the current specifications. I have a link to them there. But starting with data collection for Q1 2020, so January 1st, there are revised EDTC measure specifications. If you flip to the next slide, it kind of highlights the timeline and the activities that have been going on. You may have heard us talk about a pilot that we did this summer. We had a good handful, about 40 hospitals that participated in a pilot using the revised specifications. We've been updating those based on input from the pilot, and we'll have those released soon. The primary changes to the measure, I think we've talked about this in several different forums, but it's really a modernization and simplification of the measure. I think that your hospitals will be happy with it. It reduces the number of data elements that they're gathering information on from more than 20 down to 8. We worked with a technical expert panel back in 2018 to identify those changes. So it's going to be a fairly significant change, and we'll be doing lots of communication about it, which is highlighted on the next slide. So here's all the different ways that you're going to be hearing from us in the next month or two. We're going to try to be making sure that there's lots of different formats and ways that people are getting this information. The revised specification manual will be available the first week in December. We also, lots of states use the Stratus Health Excel data collection tool, so that will also be updated and posted in December. And we have been having regular communication with known vendors of other EDT data collection tools, so Rural Wisconsin Health Co-op and Advantage, Stroudwater, and then several sort of state-based partners that have their own EDT data collection tools that the hospitals use. We've been in touch with those folks so that they're aware of the changes and are preparing their tools for that change. We will be doing live critical access hospital training in December. We'll have 3 options. The dates are there. We will have registration available soon. There will be a recorded training posted in January. You'll be getting several emails from our team with more details and reminders about this, and we will also be using MBQIP monthly as a communication mechanism. So most of you already just send that on to your hospitals anyway, but that is another tool for you to use. And then we'll also be, because folks get information in lots of different ways, be working with some other partners, NRHA, RHI Hub, and the like, to make sure that word is out as well about the changes to that, because we certainly would hate for a hospital to collect a quarter's worth of data using the old specifications. So that will be a big focus over the next coming months. And then the last slide I just wanted to share with you, EDTC stuff is really kind of in the weeds on data collection, but we're also excited that we've been able to start working with a new program that we're calling the Virtual QI Mentor Program. The picture is Sarah and I with our 8 QI mentors. These were folks that the state flex programs nominated, they're hospital critical access, hospital quality folks that are high performing, and state programs nominated them to participate. Sarah and I had the enviable job of having to pick out of lots of great applications. So we looked for kind of a mix of geographic representation. We had a kickoff meeting with the folks at the NRHA Critical Access Hospital Conference in September. They're a super fun group. We're really excited to be working with them. And we will start to disseminate learnings and strategies and stories from this group in early 2020. So if you click on the link, it'll have a list of all the folks that were mentors, and we're just really excited to be working with them. So that is it for my updates, unless there are any questions.
Thank you. Any questions? *2, or please utilize the chat box on the left. All right, hearing none, we will move to Nicole Barnes from the Flex Monitoring team. *2 will unmute your line.
Hi there, can you hear me?
We can.
Okay, great. Hi, everyone. Just a quick update from the Flex Monitoring team. Last month, we released a new policy brief on CA participation in Flex financial and operational improvement activities for the years 2015 through 2018. And so you, if you haven't checked it out already, can find that on our website at flexmonitoring.org. Right now, we're wrapping up several projects, including a look at data sources for monitoring and supporting rural EMS, and assessing the role of cause in the opioid crisis. We're also launching a few new projects that are evaluating our main research areas of quality improvement activities, financial performance, and community engagement. An exciting project is related to the social determinants of health, and I think many of you probably responded to our survey earlier this fall about projects that CAUs are undertaking to address social determinants of health. We're now on phase 2 of that, and we're interviewing CAU administrators to kind of learn more about these projects. And phase 3 will be a few site visits that our researchers are going to arrange for more data collection. We should have a report out on that probably early next year, so keep an eye out. And then finally, we're also beginning a website redesign for the Flex Monitoring team that we hope to launch late spring, early summer 2020. And if you have any comments or suggestions on our current site, what works, what doesn't, please feel free to reach out to me. I'd love to hear your comments. And I think that's about it. Thank you.
Great. Thank you very much, Nicole. Any questions for the Flex Monitoring team, ARCITA, or the federal office? *2 will unmute your line, or please utilize the chat feature. All right. Our next topic will be population health, the return on investment, and other opportunities. Please take a moment to complete the polling questions, and we'll have another set of these as we close out the webinar, but we want to make sure we gather information prior to the webinar, and then at the end, we, as you guys know, we will utilize these for our evaluation purposes to make sure our webinars and all of our educational offerings are beneficial and relevant, and that we're making an impact. All right, just a few more moments here. If you've not taken the time, please take a moment to complete the polling question. Concerning my knowledge of the return on investment of population health, I am. We have a 5-point scale between unfamiliar and extremely confident, as well as concerning my knowledge of how to use the population health readiness assessment in my state, I am, again, between unfamiliar and extremely confident. All right, guys, thank you very much for taking the time to complete the polling questions. Tracy Morton, *2, will unmute your line.
Excellent. Thanks, Caleb. Hi, everyone. This is Tracy Morton. I'm the Director of Population Health at the National Rural Health Resource Center. And one of the major roles that I play here at the center, aside from oversight of the execution and development of some of our community and population health related work, is management of the TASC program. So TASC is the Technical Assistance and Services Center. It's the team today that's bringing you this webinar. And we're the federally funded technical assistance center that supports the 45 states that participate in the Medicare Rural Hospital Flexibility Program, or the FLEX program, and the critical access hospitals that you all serve. So thanks today for joining. I could see from the polling questions that this is certainly a topic that is needed to kind of increase some awareness of, and we as a team landed on this topic mostly through review of the core competencies assessments that the state FLEX programs take periodically throughout the year, and recognizing that knowing how to address community health needs is one of the lower scoring areas within the core competencies assessment. So that's how we landed on the topic today. Also realizing, too, that there's many state FLEX programs now that have dived into population health related activities within their FLEX grants or FLEX cooperative agreements now in the new cycle that we're within as well. So today, just like the polling questions kind of landed at, we're looking to improve your learning to recognize at least the factors that influence the return on investment, or ROI, of population health. Recall some different scenarios from the Population Health Toolkit and how to use them, and we'll be doing a live demo of what that includes. And then discuss the purpose and the benefits of the Population Health Readiness Assessment to the critical access hospitals and other safety net providers in your state. So first I wanted to kind of lay a little bit of a framework with a definition about what it is that we're talking about with population health. So we at the center, the National Rural Health Resource Center, really like this definition from the American Hospital Association. And it talks about population health being really a strategic platform that can be utilized to improve the health outcomes of a defined group of people. And it looks at 3 different stages. It looks at the distribution of certain health statuses and outcomes within a population. So the number of people that have diabetes, or the number of people that are eating all the servings of fruits and vegetables that they should be today. The factors that cause that present outcomes distribution. So again, it could get back to food sources. Are there inadequate healthy food choices within a community, or is there an abundance in a community that allows them to be able to make those choices that meet those fruits and vegetable needs for the day? And then the last part of that strategic platform is to look at different interventions that can be deployed to modify those factors and really ultimately help improve those health outcomes. So that's what we're talking about when we're talking about population health. To clarify population health, and I alluded to it a little bit there in some of my paraphrasing about that definition, is that it's a situational definition. So it can be used in conversation when you're talking about a specific targeted population. So for example, looking to improve health and maybe reduce costs for a very specific group of patients. So maybe those within XYZ rural community that all have diabetes, for example, or all have a certain insurance type. Or you could be talking about total community health, where we're looking at changing the health outcomes and the influencers on those things for an entire group. So that could be a complete market share for a critical access hospital. It's often geographically defined, and again, looking at the different distributions then within either that targeted population or that total community health population, but what it is that can help move the needle. So something very important when you're having a conversation with somebody about population health, to really clarify situationally what it is that they're talking about, a specific targeted population or a large group or area. So when we think about how it is that we need to demonstrate value, the influence is coming from a variety of different sources. So the Centers for Medicare and Medicaid Services years ago implemented the quality strategy. And their strategy mimics that of the Institute for Healthcare Improvement, IHI, which first originally coined and came up with the triple aim. So the CMS quality strategy talks about 3 aims, and that is influencing better care, healthier people and healthier communities, and smarter spending. So you might be able to see here that clearly that second check mark there about healthier people, healthier communities absolutely relates to population health. But the other 2 factors about cost and about better care certainly do too. Our value equation there is actually missing the division line, so sorry about that. But when we look at the equation for value, we're really looking at quality plus experience, then ultimately divided by the cost. The term population health management is something that should really be used to distinguish differently between population health. So these are some definitions here and some insight I wanted to share again from the Institute for Healthcare Improvement. But this helps, I think, maybe to articulate what it is that our rural communities need to do about population health in more actionable terms in this greater concept or the strategic platform of what population health is. So population health management is really about the doing of that. So managing and paying for healthcare services for a discrete or a defined population. And what we're really doing is often then best conceptualized under population medicine, and it talks about these factors such as designing, delivering, coordinating, and paying for high-quality healthcare services. Again, getting back to that triple aim or to the CMS quality strategies and their 3 aims for improving populations using the best resources that we have available. So today, where we see that playing out is in things like accountable care organizations and risk stratification methods that those entities are using, in patient-centered medical homes, and in other models where there's team-based care, part of a comprehensive approach to improve the health of the population. Chronic care models are another example that we're familiar with in rural areas, and they move that culture and that healthcare entity from reacting really to those acute or episodic care needs of the patient to a proactive kind of restructure of the healthcare delivery to meet those patients' needs and kind of get ahead of the curve of those needs as well. Population health management does require different partnerships for the providers and the payers. It requires the utilization of data and different technologies, not only to provide the patient care, but actually to look at the information on the backside. It requires a focus on looking at our workforce and maximizing the workforce that's available, but also thinking about non-traditional healthcare workforce, using different care models, and then absolutely, of course, shifting from this fee-for-service delivery model that our country has been in for years into one that focuses more on value and, of course, has some financial risk-bearing along with it. So whether hospitals or clinics are kind of working right now to understand how they can play a part in that or actually part of it, they need to be looking to extend their reach within their community for collaboration purposes to kind of get upstream of all these efforts. The Institute for Healthcare Improvement kind of further defines what they think the next frontier will look like for 10 more years about both population health and population management and medicine. And they talk about it with developing new collaboration and new governance structures, using new skills to assess and segment populations, new approaches for going to scale, and most importantly, new approaches to address the moral imperative of understanding and reducing inequity in both health and healthcare. So we wanted to provide a little bit of information about why the system itself, the healthcare system, is changing. And sometimes it comes down to finance as well. So I think when we've talked about this many times through various different webinars about the broken healthcare system and how legislative changes have moved to address that, as long as if some of the really big health systems within the country are certainly leading the charge with this as well. But we know that the industry itself is not sustainable. So if we look at this graph here from the National Rural Accountable Care Consortium and looking at projected federal spending on Medicare and Medicaid, we can see that not only do we need to be managing these costs, but to meet the needs of a population that's also aging, we also have to improve the individual and the population outcomes so that we're not continuing to have this excessive cost of the care that we're providing. So federal spending is certainly monitoring this. And then insurance premiums all along have been changing too. So even before there were some legislative adjustments to healthcare insurance, the costs are going up. In the graph, which I realize is a little small here, the small firms are in the dark blue line, and large firms are in the light blue line. And what this is looking at is, thanks Andy, is the average annual premium for covered workers by family that have family coverage through last year. And you can see that this trend is just going up and up and up. It's certainly impacted by the health outcomes in our country. And I think we all, as consumers of healthcare, recognize this too. We realize that never is the cost of healthcare really to us in our individual pocketbook going down each year. We know that our employers also can't absorb those changes in premiums every year too, so sometimes those costs are passed along. So when we talk about the individual pocketbook, there certainly continues to be changes there along with that upward trend as well. We know that there's increased growth in those high deductible health plans, and this is looking at the percentage of covered workers that are enrolled with a plan with a general annual deductible of $1,000 or more for single coverage. So again, kind of a similar thing where the small firms are in the darker blue line and the large firms are in the lighter blue line. So growth certainly isn't sustainable for the organization. It's not sustainable for the individual pocketbook. And then we know that our Medicare margins are going down as well. MedPAC produced a report to Congress in March of this year, noting that Medicare margins in hospitals, and that would be all hospitals, are continuing to decline. So we have an aging population, we've got increasing premiums, increasing costs to individuals, and then dwindling reimbursements through our traditional methods that we're familiar with. And then the Centers for Medicare and Medicaid Services is also utilizing site-neutral payments to level some of the playing fields as well. So what that means is, and generally speaking, there really isn't an option to receive an increase in payment for our healthcare facilities other than participating in a value-based payment model. And we recognize that that oftentimes assumes risk as well. But we know that embracing these delivery system changes not only is the Centers for Medicare and Medicaid and Medicare Services, but also our payers and certainly the industry as well. So the big question then becomes, when does the risk of not participating in a value-based model or in population health outweigh the risk of participating in it? So some things that I think consider for our rural facilities, and they know this, is that word of mouth is an incredibly strong marketing strategy, particularly in our rural communities that are very close-knit. We know that hospitals' data about quality of care and patient experience and even provider reviews are available online, and the population is certainly shopping around. And these are, and thirdly, that lack of data is perceived negatively by the consumer. So if there isn't data showing there, you might move along. I know that when I'm personally shopping on websites like Amazon, for example, and looking to buy a product that I could buy from 20 different vendors, if there's not a review on the product, but there's something similar from a different company that has a bunch of reviews, I'm more likely to purchase from there. And so those last two bullets there really lend to increased reasons for participation in quality reporting in our facilities, particularly in that MBQIP project too, which many of the rural facilities are participating in. So if we bounce back to that value formula, again, that CMS quality strategy, looking for better care, healthier people, healthier communities, and smarter spending, that value formula really becomes the way to navigate the risk of when to participate. So what we can do with this formula is we can look to drive down the cost by reducing preventable admissions, reducing duplication of services, reducing preventable emergency room visits. And our community members in our rural areas are desiring this. And I recognize, though, that this does reduce some of the revenue that a hospital may be receiving. In the quality arena, we can look to increase quality by improving health. So we can fill in gaps of care. We can create access. We can manage patients through evidence-based processes, and we can participate in prevention and wellness versus just that acute episodic care. So those are all opportunities that present itself to our rural facilities. We could also increase quality by improving care. So we can provide prevention and wellness services, utilize some new codes and services for care management, and certainly utilize data to inform our facilities of patient needs and service lines, and then document thoroughly, which I'll talk about in a bit. So again, these are all opportunities to expand what it is that the hospital may be providing, or leverage some of its operations to provide the right services at the right time to the right population. So ultimately, we can support population health by then supporting and engaging in community health throughout that community, really having our facilities be that anchor institution that can tie together the wellness of a community through focusing on wellness initiatives, and then focusing on population health management. So again, that design, delivery, coordination, and then ultimately payment for high-quality healthcare services. Many of you have likely seen this slide before, or content like this before. And when we look at the effect of health outcomes, this is information from the county health rankings and their model. But when we look at what influences health outcomes, be it good or bad health outcomes in an individual, the influencers are kind of divided into these 4 different areas, which are not equally distributed, as you can see here. So the social and economic factors that may influence the health outcomes of an individual equate for 40% of that kind of weight, if you will. The health behaviors, so the choices that we make, the fruits and vegetables that we eat, choosing to brush our teeth or not, whatever it may be, equate to 30%. The physical environment, so the places that we choose to live or that we are placed to live due to circumstances, equate to 10%. And then the effect of clinical care on our health outcomes is really only attributed to 20% of the care. So we're spending this exorbitant amount of money in our rural facilities and our urban facilities on managing care, and often doing kind of that fix-it care versus the wellness care, and only having that 20% impact, if you will. And so what this says to us is that healthcare, of course, cannot alone fix the health conditions of our country, and that we need to be working outside of our practices and outside of our walls to really influence the changes that can be occurring. So this is kind of where the rubber meets the road, I guess, if you will. This is where the return on investment can really be identified and explained further for participation in population health. So there's opportunities in our rural facilities, critical access hospitals specifically, to expand services through funded workforce. So we can build our primary care capacity, and I'll talk more about each of these points. We can build our primary care capacity. We can have nurse-led programs that support an increase in primary care demand, and we can increase the revenue to support more population health staff. So this is some information that I'm sharing with you from Shannon Calhoun, who's a national rural ACO expert. And so what she shared with us is that to build that primary care capacity, population health management requires 1 hour a year more in visits for every Medicare patient. And those care management can create the need for the right time visits. So if we do 150 annual chronic care management patient visits within our facilities, that will pay for 1 nurse. Wellness prevention services kind of build that strong relationship with those patients, not just those that have chronic conditions. So those wellness and prevention services actually keep people coming back. And 3 annual wellness visits, which is the Medicare opportunity, a day will pay for 1 nurse as well. we look into those nurse-led programs that drive that primary care demand, they're really meeting the patient's needs with the expertise that can be leveraged from a nurse or a medical assistant. They support provider needs too. The patient receives really that right level of attention when they need it the most, and it's not utilizing a higher cost professional. So it really allows everyone on the team to operate as a team and operate at the top of their licensure. And lastly, there's a lot of opportunities then that are available for population health revenue streams. So I'm not going to go through the litany of different things here on the screen, but what you can see is that with some of these, and quite a few actually, there are opportunities here to collaborate with the community as well too, to leverage the services and expertise that may exist in that exact community, in the neighborhood community, or in a region as well. I have a link here at the bottom in a box to a webinar that we've done before about mastering hierarchical conditions category coding. This is really an imperative thing for critical access hospitals or rural facilities to learn how to do. What this allows us to do is to capture the complexity of the patients that we're serving within our facilities to maximize payments, but it also allows you to improve your data integrity within your facility to be able to analyze the true patient population needs that you have and to predict the future needs. So this is it's certainly very, very important if you are participating in a value-based model to maximize the payments and identify the appropriate risk. But it's also a very good thing to be doing if you're not participating in that too, to really be able to best describe who the patients are that you're seeing and getting paid for them accurately as well. So when I was doing some research into is there really an ROI in population health, it's kind of a mixed bag right now, it really seems. So it's kind of a yes or a no. Are we improving health and decreasing payments? Maybe, maybe not. That's certainly our end game of improving health. Will that decrease payments ultimately to the rural facilities? Yes, maybe in the classic ways that we've been paid in the past with the services that we've been doing, but that's not what our population needs, is the continuation of the services that we've been doing. They need an expansion into services that are providing care in different avenues, including at the home, and in different methods like wellness and prevention, like I mentioned many times already. So most of the classic ROI methods for analyzing what that value might be for population health is really based in a system that has full integration system-wide of technology to analyze utilization and report on quality and cost. So it needs some data analysis, some risk stratification, all the things you can see there under that bullet. So what we know, though, is it's meaningful, though, to be able to think about ROI for population health if you're not in a value-based model as well, or if you don't yet have that technical expertise in your facility to do that data analysis and risk stratification, et cetera, et cetera. And really, how to think about that is through managed care, reduction of leakage, and unwarranted care. So managed care, I think, is understandable. You know, fully coordinating the care of the patients that we're working to support. But regarding reduction of leakage, we're looking to have patients essentially not go out of network, and we're using our IT tools, our care managers, our local resources, and leveraging them to keep that care local. And that's what most of our rural citizens truly want anyhow. And then as far as looking at unwarranted care variation, here we're trying to streamline costs and operational efficiencies. We have lean shifts already within our critical access hospitals. It's just making sure that those shifts are really as tight and as seamless as possible. This is particularly important if you're working with private payers. Of course, you have that negotiated payment. So if your cost changes with the patients that you may be seeing from time to time with that cost variation, you're not going to get paid differently necessarily. But with cost-based payments in our CHs, we do have the ability to absorb some of that variation. But the more we can streamline our efficiencies, the better practice it is for our facilities in the end game, and the better practice it is as well to move into value models in the future. So the big questions kind of become, does investment in population health really help us as a facility grow? Does it help us maintain a presence and a role within our community? Does it help us maintain a margin? And again, back to that, when does that balance shift from that risk to the reward? So what we do know, and you've heard organization talk about this many times too, is that rural is this foundation for primary care, and we're really well positioned to do population health, management and population medicine. The basis for healthcare transformation is population health, it's prevention, and it's wellness. And it's that connection and understanding to the community. We certainly have that in our rural areas. So rural is really well positioned and excels at adopting and adapting. We know that as well. But we have to use data to describe what our current needs are and predict the future needs, and as well as demonstrating that value. So that's through that cost, that patient experience, that quality of care, that whole value formula. And again, that's why that hierarchical condition coding is so important for proper documentation. So those are the things that I wanted to explain about return on investment for population health. I'll pause here before we shift to talking about what the population health toolkit is and see if there's any questions or comments. So again, it's star 2 to unmute your line. You can raise your hand in the top left button with the person with their hand raised, like Caleb noted before, or certainly use the chat box as well, and that's star 2, again, to unmute your line.
Tracy, this is Terry Hill. Just another comment here on that return on investment. I've spoken to probably hundreds of hospitals over the past years on this concept, and I think at this time most of the hospital leaders recognize they're going to have to move into population health and population health payments. The urgency to do so, however, is often kind of disrupted by the very real crises they have at the moment, meeting payroll, for example, trying to position the hospital effectively, perhaps with another healthcare system, et cetera, et cetera. So one of the things we know is that our rural hospital leaders have a ton of stuff on their plate already. Now, the most progressive ones and the ones best situated, perhaps, and understand where the industry is going and where the payment is going are launching out into these directions and actually starting to, do some really very innovative work in this area. But if you look at the balance or most of our critical access hospital leaders, one of the things that I found most effective in working with them is to talk very much about the fact that when you work with your community, when you enlist partners, when you start to make an investment here, you also are able to help to market the services that you have available locally. And again, the center for years and years and years have been doing community health assessments, and what we find over and over and over again is that most of the people in our rural communities don't know what services are available in that hospital. Dr. Ira Moscovitz from the University of Minnesota told me part of the problem is what he described as almost the shocking condition of their websites, and that's picking up on what Tracy has said before. It's like when our families are, and I don't think this is just young people, I think generally people in general go to the website, and if they don't see COPD services or respiratory services available, they figure they're not available. So one of the things that has actually hit a chord with the hospital leaders as I talk to them is to say, you've got a ton of out-migration for care. You may be losing more than 50% of all the money that could be coming in for primary care and outpatient services, et cetera, but you're losing it. And if you start now working with your communities, there's a real an immediate return on investment. It's like we can keep another 5 to 10% of the revenue that we're losing through this out-migration. We're going to really help to stabilize our finances. And so, again, it's just my experience that so many of these hospitals are either in desperate straits or are very concerned about the future. And if we can motivate them a little bit by talking about not only is this the right thing to do long term, but it's something you could immediately do and get out there in your community and not only enlist partners in population health, but also let all these folks know and enlist them to help let other citizens know that services are available. This hospital is competent, it wants your input, etc. So just another thought.
Oh, that's great, Terry. Thanks for sharing. Does anybody else have any other comments or questions? So I think one of the questions that might be out there is like, this is all maybe hopefully helpful information, but what are we as Flex programs supposed to be able to do to help our facilities besides being educated? And so the Population Health Toolkit is a resource that we designed here through TASC a couple years ago to really help rural hospitals, clinics, rural health networks, state-level organizations understand and access resources, particularly related to population health, that can be readily translated into the rural environment in the different phases that an organization might be in as they seek into this journey of population health management and population medicine. So I'm going to do a demo here for you of what the Population Health Toolkit includes to be able to show you its different features here in the last 30 minutes or so of our call. So as I'm switching here to my screen, I wanted to show you how to be able to navigate to it from the National Rural Health Resource Center's main landing page. So our website is ruralcenter.org. And when you come to our website, if you click on Resource Library, this is where you really find all the litany of different resources that we have that are housed not specifically within a different program. And the Population Toolkit is over here on the right. You can always use our search box up here at the top and type Population Health Toolkit or even Toolkit, and only a few different things will come up. But this is the Population Health Toolkit. If you've been in your position for a little while, you've actually probably heard of this before. We used to call it the Population Health Portal. And then we realized that portal was a really jargony term that didn't maybe mean as much to the end user as what we were intending about what it included. It's the Population Health Toolkit, or the portal, is not a secret passageway into a different universe, as a portal may allude to. It's a really cool thing, but it's not a secret passageway. It's a collection of different resources and tools, and so a toolkit is probably more descriptive of what it is. So the toolkit itself has 3 different major sections to it. And all the content within the Population Health Toolkit is structured around the Performance Excellence Framework, which takes a holistic approach to any kind of change or organizational structure that you're looking to move through. So a very balanced approach. There is a resource library within the Population Health Toolkit, so a collection of resources. There's an assessment, and there's some data scenarios. So the resource library down below is organized into 3 tiers of getting motivated, getting informed, and getting going. And getting motivated is really about looking for ideas and an increasing understanding of concepts. Getting informed here with the light bulb is about tools and resources and case studies to start applying practices. So within our our Performance Excellence Framework, this really focuses on data analytics, information management, quality processes, and internal processes. And then the last section of resources are collected into the concept of getting going. So this is about tools and resources to really demonstrate impact, move into culture change related to population health. So focusing on customers, community and partners, staff, culture and change management, and then outcomes and value demonstration. The readiness assessment is a tool that many Flex programs may be aware of already. So I'll click on this here to complete the assessment and show you a little bit about what the Population Health Readiness Assessment includes. So the goal of this assessment was really to help the end user, really a healthcare facility or a network of those, or some type of consortium, to gauge kind of where they're at within the journey on population health management and help them connect with specific tools and resources that can help meet them where they're at. So there is an assessment to take, and if you've used any of our assessments on our website, it looks a lot like this, but I'll show you kind of briefly here what it looks like when you click on it. So bear with me here as I click through these different things. I'd like to show you the scoring mechanism at the end. So there's a category under leadership, an area under strategic planning, and this is an area where we actually see many facilities so far scoring relatively low. It's an area about patients and partners and the community, so I'm just kind of randomly clicking things here. Data collection, management, and analysis, again, an area that we often see facilities scoring lower. Operations and processes, the workforce culture, and then outcomes and impact. And then the last thing you need to do into this is to put in your information about who you are so that it comes to you. So bear with me here. Here's a chance for you to all write down my email address if you have questions at the end. Oops. And so what this will do is it will send you an email of your score, but it will also generate a scoring page for you. So there's a hyperlink to my score, and of the 105 total points possible, my organization scored 68. So the best way to take this assessment is actually to sit down with the leadership team within your organization, or those who are intimately involved with what aspects of population health would look like if you haven't yet implemented any strategies, or those that are currently doing it too. And so what this is saying is that, way to go, our organization is beginning its journey. We're about halfway through maybe the scoring of this. And it then pairs me up with resources related to where I'm scoring lower. So I was scoring lower essentially under leadership and planning, and particularly, if I remember exactly where I was clicking, under some of the strategic planning things. So it's helping me to understand what some of these resources could look like based on my score. So how to engage my board, working to identify populations, understanding a framework, et cetera, moving from vision to action. So some resources that might help you get going. We recognize that there's a lot of resources here, so you always do feel free to reach out to our organization, explain a little bit more about where you're at, and we can help you find the resources that fit your needs and certainly help you tailor those to needs too. So when I would get the email then that would have came to my email box, this link would have been provided there. A heads up though quickly to the State Flex programs that might be using this readiness assessment in your work plan for your Flex grant this year and the future. The readiness assessment was designed with the end user in mind, and the end user for the assessment is really truly those rural organizations. And so we didn't want to put any restrictions on it that their information would be immediately accessible to others who might request the information. And so that's why we don't have a checkbox on here. We know that we've received some requests from some of the state programs to add in a checkbox when someone is immediately taking the assessment to be able to have the information funneled straight along to the State Flex programs. But we recognize that in some instances, and this is a marketing opportunity for our Flex programs, is that sometimes our CHs actually, or rural facilities don't know what the State Flex program is or what the State Office of Rural Health is. And of course we want to change that, but we didn't want to inhibit that an organization using the resource because of having that checkbox on there. So the strategy for a State Flex program to be able to access that information is just to reach out to your rural hospitals that you would like to take the assessment and have them send you consent that we can share their raw scores with you. We can certainly send you average scores and roll-up information, but if you'd like their raw specific scores per facility, if you could obtain consent with them, let us know what date that consent was achieved and email it to us. Just that you have approval from XYZ facility on whatever date, we can send you that data. I see that there is a chat in the chat box. And thanks, Lynette. I'm glad that you like the resources that are available in the Population Health Toolkit. It's something that we're constantly maintaining and curating. So I'm going to go back to the main toolkit page. So I'm just using the breadcrumb here at the top. And here on the toolkit now is the part where I wanted to show you data scenarios. So there's been data scenarios in the Population Health Toolkit since its inception. And the purpose of those data scenarios is that we recognize at rural facilities that there may not be a data analyst on staff. Or if they are, they might not be looking at population health related content. They might be looking at something else as well. And we know that many rural facilities rely on secondary data, so data that exists out in the public universe for utilization to inform some of the choices that they're making about their rural community. But we recognize that sometimes comparing those different data sets together to answer questions can be really challenging. And so what this tool does is it crosswalks 4 different publicly existing data sets to answer 11 different scenarios that exist that might help a rural facility make some choices about population health. So if I go to this section called Putting Data to Use, you can see on here that the list of the 4 different data sets that are utilized. It's Hospital Compare, Medicare data from Dartmouth Atlas, County Health Rankings, and then the U.S. Census Bureau. We update the data sets in this toolkit annually at one time. So the data is updated then. So the most frequent source of that data would always be originally at those sites. So there's 11 scenarios that we've put together. You can see them on the far right here in the blue box, or you can scroll down to see the rest of them as well. And they include things like looking at diabetes and demographics, looking at emergency department utilization and mental health shortages, looking at transportation and health status, et cetera. One scenario that I won't be showing you today, though, that is really interesting is utilizing claims data. And what happens in this utilizing claims data, and I'll just click on this actually quickly, is it talks about how claims data can be beneficial to a rural facility. So I won't spend the time here reading through that. You can do that. But it provides 2 different videos in here that guide a user through accessing a set of synthetic data from Medicare. So what CMS does is they take Medicare claims data and they jumble it all up. So it's real data, but it's all mixed together, so it's not identifiable, and it's actually not a real person. And it's a synthetic public use data file, or this DSynPUF file. So facilities can use this to practice analyzing claims data with what the data would look like as far as categories go, at least for Medicare data, but without messing with real data and, of course, without having identifiable information. So the first video guides you through how to access this synthetic data file. And then the second video guides you through using a tool called R to analyze this claims data in ways that could be meaningful. So it's a really great way to practice using claims data, and then you can move forward into deploying it within your facility too. So just wanted to take a second to highlight that. The other data scenarios then are kind of crosswalking those data sets, like I mentioned, and what we did this year with the data sets is put on top of the data sets a visualization tool called Tableau to allow us to look at the data a little bit differently. So the first data set, or the first scenario I wanted to show you, is about looking at social economic status and well-being as just a demonstration here. So each of the scenarios are set up similarly. They talk about why the scenario might be important. So this one's looking at some health outcomes and comparable factors that might influence health, specifically those around social determinants of health. So it talks a little bit about the purpose of the scenario. Then there's the data display in Tableau, and I'll come back to this in a second. And then all of the videos have their own unique video tutorial about how to use that specific data scenario as well. Down below, they talk about where the data sources come from for this specific scenario and what the different data definitions are. And then there's always a tutorial about exporting this data into Excel, which you can do as well. So to go back up to the actual output of the data for this particular scenario, the first thing I'm going to do, and this is the first thing it tells you to do in that video about the video tutorial, is to expand it into full screen view. So if I take a second here and allow Tableau to load. Again, this is the data output where it's looking at socioeconomic status in some factors that might influence well-being as well. So when you first come into the Tableau data output, we see all the states and actually all territories that have data for this particular scenario. So what you can do over here in this top left box is about looking at the state or county premature mortality rate, so it's age-adjusted mortality rates. So first here we're looking at all states and territories. I can click specifically, say, on Colorado and see that in the state of Colorado there are 315.5 premature mortality deaths per 100,000 population annually on average. I can also see, because I clicked on the state of Colorado over here, the state average Medicare reimbursement rates for all Medicare payees at roughly $86,000. So different states have different values. And down below, in the other subsequent kind of scatter plot graphs, now that I've clicked on the state of Colorado, I'm only seeing data for the state of Colorado. And if I highlight over the different dots on here, it shows me the specific counties. So this is where some of the data gets crosswalked further than in this scenario, is where it's looking at this top left scatter plot graph is looking at the average diabetes prevalence, so from 5% up to 10%, and the average income inequality value. So as income inequality increases, that means we have more income inequality. The trend line here is showing that the prevalence of diabetes increases as well. In the state of Colorado, as average food insecurity percentage increases, there's a slight trend increase as well in the prevalence of diabetes. And I think not to be unexpected, as the average diabetes prevalence increase again here in this right graph, the average preventable hospital stays also increases. Down below, it's looking at preventable hospital stays with some social determinants of health factors, so those things that can influence health outcomes. As the average median household income increases, the average percent of preventable hospital stays decreases. As the income inequality value increases, so again, income inequality becomes more prevalent, the prevalence of preventable hospital stays increases. As the average limited access to healthy raw foods increases, so limited access increases, again, preventable hospital stays increases slightly as well. And as residential segregation increases, particularly between Black and white communities, as segregation increases, preventable hospital stays decreases. So that's an example of what that county level data looks like. Again, if I go back up here to the top, click on, excuse me, on the state of Colorado, and you can come, oops, I'm sorry, you can come to the top here where there's this little plus sign. You can sort these things all differently if you'd like, alphabetically by the actual mortality rate, because that's what this data set is about right in this box. But I can also click on the box here with the plus sign, and in a second, it brings up all the counties. So I'm going to have to take a minute here and scroll to Colorado just to continue with demonstrating that. And Paul, I did see your comment. I think you were asking for the presentation, and we will certainly send it out. Thanks, Andy, for commenting back. So Colorado still is highlighted in blue. So this is an opportunity where before we were looking at what the state level benchmark was for the average mortality rate, and it happened to be 315.5 deaths per 100,000 population. Now I can see specifically Adams County, for example, has 322. So compared to the state rate, this is slightly higher. So just an opportunity there to filter down to the county level. So to flip back here and exit out of full screen, that's one scenario I wanted to show you about socioeconomic status and well-being. And then I'll pull up one other scenario for you. So for this, I'm just going to navigate here over to the blue side just to show you a different way to navigate around the website. And we're going to look at the scenario that's looking at uninsured rates and behavior and mental health. So the purpose then of this scenario was to look at and compare the rates of poor mental health days by rates of things that could influence that. So health insurance coverage, the number of poor physical health days, employment status, income level, teen birth, excessive drinking, all potential stressors. So again, same sort of layout as any of the scenarios where there's a description about what the scenario includes, the Tableau output of the data, a tutorial, and then the data sources and definitions, etc. One thing I do want to show you before we look at the Tableau output is that the data is always available still in the text-based table format. So that was the way that the Population Health Toolkit used to look. So to click on that quickly, if you've seen it before, this might look familiar. This is what it looked like before, was data in a table format. So same sort of values. What we've done with Tableau, like I said, is just put some data visualization in it. So we can look specifically here, say at the state of Mississippi, and at, I was looking at this earlier, so at Bolivar County, and we can filter the data specifically to Bolivar County, and here we can see the state benchmark. We could, filter these things. If you hover over the titles at the top of the columns, it tells you the data definition for what that is. And I can always reset it, and maybe I could just filter specifically to the state of Indiana, for example, apply it. I can see the benchmark for Indiana, and then all of the counties are listed. I can filter these counties if I'd like. And the other cool thing that you can do in this table format is you can export and download the data into a comma-separated file or a CSV file, which allows you then to import it into Excel. And you can manipulate the data however you want. You can import it into other things too, but Excel is maybe more commonplace for our state flex programs. But you can import it however you want, then manipulate the data, make your own charts and graphs, and do cool things with it too. So just wanted to share that this table format of the population health toolkit and the data scenarios didn't go away. It's just a different way to look at it. So I'm going to navigate back to the toolkit instead of hitting the back, go this way. Go down to these data scenarios again, and I'll lastly just show you the Tableau output for this particular scenario, which again was the uninsured rates and looking at behavioral and mental health. And this is a little bit bigger of a data file because it is using data from census and then county health rankings, I believe. Yeah, county health rankings. So bear with me as some of this might take a minute to load, but hopefully it won't be too slow. So again, the purpose of this scenario is to look at factors that might influence poor mental health days. And so the first graph in the top left is looking at, again, we're kind of in the state view, so it's looking at the state uninsured rates, and they're sorted from highest uninsured rate to lowest uninsured rate. So we could sort that differently if we wanted. We could sort it by alphabetical order. And then the graph over to the right, the nice map, is showing with gradient shading, the average poor mental health days per month. And so we were talking about Mississippi before, so if I just click on the state of Mississippi, wait for it to load. In Mississippi, if I hover over it, about 15% of the population that is age 65 and under but of working age is uninsured, or excuse me, 65% 65 and under are uninsured. And I'm going to zoom in on the map because Mississippi is awfully tiny there. Hang on a second here. And since I've selected the state of Mississippi, I can now see gradient shading by the different counties, which is kind of neat. We were talking about Bolivar County before, so here in Bolivar County then, I can see specifically that they have an average of about a little bit over 4.5 poor mental health days per month when they're within their adult population that was reported. The graphs down below are now still looking at the whole state of Mississippi, even though I have Bolivar County highlighted in the map, and they're looking at other factors that might influence poor mental health days. So the vertical axis is looking at the number of poor mental health days per month, and then the horizontal axis is different variables. So average median household income, excessive drinking, unemployment, percent uninsured, and average teen birth. Just like before, and you can, under this top left bar graph, click on the plus box to have all the county level information show, and that gets real busy real fast. And again, you can kind of highlight your specific state, and now an error came up. So we're going to go out of this for now, but I just wanted to be able to show you what that looked like there. So I encourage you to come in and monkey around with this. You can also, from this screen level of the tool set, or excuse me, of the toolkit with Tableau, you can share the content with other users. You can download what the picture looks like as well too. So those are the things that I wanted to be able to share with you today about the Population Health Toolkit, and hopefully that it's beneficial and useful for use within your state flex programs. With that, we can turn it over to any questions or comments people have about any of the content that was presented today. I'm happy to field those questions.
Again, *2 will unmute your line, and we can refer you again to the to the figure up above where you have the raised hand, agree, disagree button. Or please utilize the chat feature for any questions you might have. As we wait for questions, thank you, Nicole, for your comment. The presentation is also available for download below, titled Population Health. Please take a moment to answer the polling questions. Again, we want to make sure we are offering education that is beneficial and relevant for you guys and making a change in your knowledge. So please take a moment to answer the polling questions. Concerning my knowledge of the return on investment for population health, I am, and please rate your knowledge between unfamiliar and extremely confident. And concerning my knowledge of how to use population health readiness assessment for your state, unfamiliar to extremely confident again. As we complete the polling questions, I will draw your attention to the bottom right for the upcoming events. Please remember to update your state flex profile by the end of next week, November 22nd. The form is there in a link in that button. The November MBQIP, Medicare Beneficiary Quality Improvement Virtual Knowledge Group webinar that our KETA sponsors will be Thursday, November 21st. And if I remember my notes, well, that is National